take questions maybe during the lunch time. We'll go to the next talk, that is optimizing intradialytic hemodynamics. This is going to be told by Dr. Uh, Ramesh KN. He's the head of the department critical care medicine at Continental Hospital. He had a survey on violence on doctors and burnout in syndrome in ICU. His area of interest are neurosonology, ECMO, infectious disease, and transplant medicine. With this brief introduction, I will request Dr. Ramesh to go ahead with his presentation. Thank you.
Good afternoon, everyone. So my topic is optimizing interdialytic hemodynamics. So in that we'll see commonly interdialytic hypotension and then the hypertension also. Interdialytic hypotension is more common. Almost we'll see around 20 to 30% of the cases on dialysis who has hypertension during the dialysis, and it is more so in elderly population and in the women. It's more common. And why we need to know about this? Because it adds to the morbidity and mortality of the patients. So there are various terms used for interdialytic hypertension, in which hemodynamic instability during renal replacement therapy and interdialytic hypotension, interdialytic hemodynamic instability. So these are all the various terms, and we have many definitions also for this from the Europe, Japanese, and US definitions are there. Commonly, what we use is kidney disease outcome quality initiative definition, which is the systolic drop in the systolic blood pressure of more than 20 millimeter of mercury, or drop in mean arterial pressure of more than 10 millimeter of mercury, with associated symptoms and requiring a nursing intervention, either with a fluid bolus or introduction of vasopressor supports or like that. So this is a commonly used definition, and other definitions are there which has minor differences. Like in Japanese definition, the systolic blood pressure drop is more than 30 millimeter of mercury, and in US commonly they use the nadir of systolic blood pressure which should be less than 90 millimeter of mercury, and this nadir of less than 90 millimeter of mercury, it has a very good correlation with the mortality during the interdialytic hypotension, so compared to other definitions. So there are various symptoms also associated with interdialytic hypertension, like nausea, vomiting, dizziness, shivering, all those things. So we can classify that as acute, which is a sudden onset, first onset, or recurrent, which can occur recurrently. At least 50% of the dialysis sessions, if it is occurring, it is called as recurrent, and it or chronic, if it is persisting low BP less than 90 millimeter of mercury for many times, or chronically if it is there, then it is chronic interdialytic hypertension. So coming to pathophysiology, there are mainly 4 or 5 mechanisms we need to understand to prevent and treat the interdialytic hypertension. That is the ultrafiltration rate, interdialytic weight gain, rapid osmolar or oncotic shifts, which we call, and dialysate sodium concentration and dialysate calcium concentration, and the temperature during the dialysis. So first is the ultrafiltration rate. So as we all know, when we increase the ultrafiltration rate, the fluid volume from the blood is intravascular volume depletion will occur. So when there is intravascular depletion, there are various mechanisms which will act on that to regain the blood pressure back to the normal state. So when there is intravascular depletion, the fluid shift will occur from the interstitial or the intracellular compartments into the intravascular compartment. So as we all know from the Starling's principle and the modified Starling principle, we need to have an oncotic pressure in the intravascular space, and then the lymphatic system should be intact for this shift of the fluids. So if in case the ultrafiltration rate is more than the rate of shift of the fluid from the interstitial compartment into the intravascular space, then it will lead to hypotension. So main way is to prevent this interdialytic hypertension with ultrafiltration rate is to reduce the ultrafiltration rate and increase the duration of dialysis, either with slow dialysis, SLED, or CRIT. So we need to have a intact lymphatic system for this fluid shift to have, and if there is an abnormal or obstructed lymphatic system, they are more prone for interdialytic hypertension if the ultrafiltration rate is more. And so how to prevent this? there are 2-3 methods. One is ultrafiltrate profiling. So in which if there is a variation in the blood flow rate, or if the patient's hemodynamics ultrafiltrate change of the ultrafiltration based on the hemodynamics of the patient. If the BP is maintaining, then ultrafiltration can be increased. If the BP is hemodynamically unstable, then the ultrafiltration can come down. So these variations can be done by the machine only. This is called as ultrafiltration profiling. And second is ultrafiltration controller. So in which say ultrafiltration and the fluid removal and the intravascular depletion will occur, and it will also depend on the transmembrane pressure. So if there is a variation in the transmembrane pressure, that is hydrostatic pressure, then sometimes with ultrafiltration rate, patients are more prone for hypotension or intravascular depletion. So in that way, we can also use ultrafiltration controller, which will modify that in the machine only. And we can also use low permeability membranes, so which will not permit the free fluid of the water and free fluid, so that the intravascular depletion will not occur. So main way is to prolong the duration of ultrafiltration and reduce the ultrafiltration rate. Next is interdialytic weight gain. So when the patient comes for regular dialysis, we'll ask them to monitor the interdialytic weight gain. That means in between the dialysis, what is the weight gain they were, that is what is called as dry weight. So after the dialysis, what we call as dry weight. After the daily weight monitoring, we have to advise for the patient. Maximum allowable is not more than 1 kilo for each patient per day. So if there is high interdialytic weight gain, more fluid is required for us to remove to attain the target dry weight of the patient. So when the more fluid is removed, it will also lead to hypotension. So this there is one more device called as monitoring the hematocrit during the dialysis, which will indicate the dry weight of the patient, and which will also indicate us how much fluid to be removed. And so it can be prevented by salt restriction and fluid restriction in between the interdialysis period. So next mechanism is rapid osmolytic shift. So higher pre-dialysis osmotic serum osmolality will have higher incidence of interdialytic hypertension. So the osmolality, mainly because of the urea and glucose, will decide the patient will have whether the patient will have hypertension or not. So like this, if the patient's serum osmolality is high because of the urea or glucose, then there will be during the dialysis there will be a rapid shift of solute clearance. When there is a solute clearance, the osmolality of the blood will come down. So low osmolality of blood compared to slightly relatively hyperosmolar interstitium and the intracellular compartment, the fluid shift will occur from the intravascular space into the interstitium, so causing intravascular depletion. This is opposite to the what we discussed about the ultrafiltration rate. So this can be prevented by reducing the osmotic shift and adjusting the clearance rate. Higher the dialysis dose or the higher the dialysis urea clearance, more the chance of the patient going into interdialytic hypotension. So another concept called as isolated ultrafiltration, in which only the fluid is cleared, not the solute, in which the ultra dialysate osmolality will be increased by a solution or by mannitol or something like that. So which will lead to increase in the osmolality of the dialysate fluid and reduction in the osmotic difference between the dialysate fluid and the plasma, so that the osmotic shift will not occur and the chance of interdialytic hypertension also will reduce. So for this, evidence is bit mixed, not a clear-cut evidence is there for using mannitol in the dialysate solution. Another thing is albumin. So for any patient to maintain the oncotic pressure in the plasma, which is required for any dialysis patient when they are going through so much of fluid shifts. So the hypoalbuminemia patients are more prone for interdialytic hypertension compared to the regular patients. There are many studies to support that. And autonomic dysfunction, it could be because of diabetes or uremic neuropathy, which will cause autonomic dysfunction. And this is more so important for a compensatory mechanism when the patient goes for hypotension during dialysis. So if the patient has autonomic neuropathy, then the compensatory mechanism will not act and they are more prone for hypotension. So the mechanism mainly here are the downregulation of the alpha adrenergic receptors and the endothelial dysfunction. Commonly, we feel that blood flow rate in the dialysis will cause hypotension, but actually it is a myth. In the modern era, in the modern machines, the blood flow rate, higher blood flow rate may not cause reduce in the blood pressure because it will be compensated by the return fluid what we give, and the return fluid with the it is coming into the return circuit will be as same as the blood flow rate what we extract from the patient. So this may not cause intradiabetic hypotension. And can we predict this intradiabetic hypertension before the patients are exposed to this hypertension? There are various methods to predict that. I don't have to explain the fluid assessment for an intensivist. As we all know, PLR, passive leg raising, is one of the predicting method. And there are studies to support this also, that passive leg raising will predict the patients having intradiabetic hypertension before dialysis, when it is done before dialysis. And if the patient in ICU has a invasive monitoring like pulse wave control analysis or increment in cardiac index of more than 9% with PLR also predicts that. There is some scoring system called as Socrates score. This is a famous study, Socrates study, in which they studied cardiovascular SOFA score, capillary refill time, and lactate level. So SOFA score of more than 1 and capillary refill time of more than 3 seconds and lactate level of more than 2 millimoles. So if the score is more, then the chance of patients going for intradiabetic hypertension is also more. The score of 2 and 3 is having 55% and 80% chance of the patient going for intradiabetic hypertension. So these are all the various causes which we learned till now. So that is the volume related, intradiabetic weight gain, shorter the dialysis, higher ultrafiltration rate, and targeting the higher dry weight and low dialysate sodium that we will be discussing later. And vasodilation because of the autonomic neuropathy, temperature fluctuations that we will be discussing. And when we are using acetate as a buffer also leads to vasodilation. And cardiac factors, if the patient has a systolic dysfunction or diastolic dysfunction, or if the patient has arrhythmias, they are more prone. And uncommon cause like pericardial tamponade. I think this one we have to consider when the patient has a code blue during dialysis or something. We had 2 patients who had pericardial tamponade who was presented as a code blue during dialysis. So focus helps us a lot during this. Even once one probe can decide whether the pericardial tamponade is there or not. In that case, a pericardial drain will help, and both the patients have recovered from that. So these are all the various causes as we discussed. So these are all the risk factors: diabetic end-stage renal disease, cardiovascular diseases, and severe anemia, uremic neuropathy, hypoalbuminemia, age more than 65 years. So dialysate sodium, which will decide the tonicity of the blood. And if you are using hypotonic dialysate, the blood returning from this dialysate after dialysis will also be hypotonic. So the water moves from the intravascular space into the interstitial space, leading to intravascular depletion and hypotension. So better to maintain the increased sodium level in the dialysate solution, at least 140 to 145, or the pre-dialysis patient sodium level, so that the fluid shift will not occur and it will not cause hypotension. The calcium level also is important, because when we have low calcium level in the dialysate solution, the calcium shift will occur and it will lead to the hypocalcemia. Very commonly we'll see in CRRT patients. And so hypocalcemia is having an increased mortality and morbidity during dialysis, and hypocalcemia. So to avoid that hypocalcemia, so better to increase the calcium level in the dialysate solution, so that the cardiovascular, cardiac arrest, arrhythmias and all will come down. Inadequate vasoconstriction because of various reasons like sepsis, sometimes reaction to the dialysate membrane only can cause vasodilatation. And venous system, which is capacitance system, if there is a venodilatation, then it causes relative hypovolemia causing hypotension. And the temperature is very important during dialysis. The evidence for this factor is very high, very strong evidence that temperature management during dialysis will reduce the incidence of intradialytic hypotension. So when we use higher temperature of dialysate, it will cause increase in the temperature of the body and vasodilatation. So there are two ways. Direct vasodilation will cause hypotension, and the compensatory mechanism during the fluid shift also will act and then causing hypotension for the patient. So maintain the initial dialysate fluid temperature of 35 to 35.5 to 36 degrees Celsius and use blood temperature modules. Though this is a study which has very good evidence, very strong evidence to show that hemodynamic instability can be avoided by monitoring the temperature. So eating during dialysis, which will cause blackening vasodilatation, and this can be avoided. Dialysate membrane, probably now newer dialysis machines we are using biocompatible dialysis membrane. So this is also we have avoided. Acetate in the dialysis, instead of that acetate we can use bicarbonate. Acetate is more prone for vasodilatation and hypotension. We can also use midodrine, sertraline to avoid the intradiatic hypertension. And management wise, I'll take another 1 minute, sir. So Trendelenburg position, head low position, 0.9% saline fluid bolus, or alternatively some albumin also we can use. And so extended duration of dialysis, nocturnal dialysis also is proposed, but not having good evidence. And we also always have to search for the cause for hypertension. It can be cardiac cause, echo, myocardial infarction, or sepsis. Consider CAPD in recurrent patients. And prevention, we already discussed in the pathophysiology. Use
Dr.
of
Ramesh, can you
ultrafiltration
conclude?
controller, or limit the salt intake, dry weight, reduce the dry weight and high sodium levels in the dialysate fluid, and calcium in the dialysate fluids. Avoid antihypertensives before dialysis, and bicarb dialysate. Correct the anemia. Avoid eating during dialysis. Midodrine before dialysis. Uh, Blood volume monitor. And so there are a few studies on pneumatic compression and intradialytic exercise. Pneumatic compression will increase the venous return to the heart, but not having good evidence. Intradialytic exercise will increase the sympathetic activity and increase the cardiac output, but this also has very little evidence. So this is one deep learning study on ECG, which will predict the hypotension. With this, thank you.
Yeah, thank you, Dr. Ramesh. It was a nice and lucid presentation. Um,
I think we are short.